Okay, back to toxicology. It goes without saying that the drugs that we're going to go over now is something that we need to be thinking about. I mean, you are going to go on a lot of narcotic overdoses. They may be prescribed or illicit substances. These are the narcotics. These fall into the class of like Oxycontin, morphine, heroin, and so these cause respiratory depression with pinpoint pupils. And we already know the antidote for this. Now, I wouldn't be just giving the antidote for any of those patients because they may be habitual users, and being habitual users will cause them to go into severe withdrawals. However, just you can touch them a little bit with the antidote. The antidote again is Narcan, and follow your local protocols. This can be given IM intranasally, IV, sometimes even sublingual. Just remember, if you give it to them, it can cause them to go into immediate withdrawal, and we don't have the capability of maintaining that. So, if you can assist and support their breathing, because we know that they go into respiratory arrest. When you support their breathing, the drug will wear off. They'll still be comatose or unresponsive, or in some degree of being incapacitated under the drug, but at least now they're breathing on their own. I did not say again not to give it. I'm just saying be careful with giving it. Again, safety first. You might consider restraints prior to giving it to them, because as they come out of it, they'll be very disoriented, and there may be concern for safety of yourself, the providers around you, and even making sure that the patient doesn't get hurt. Now, again, it does cause coma. It does cause respiratory depression, and we're looking for pinpoint pupils. Narcotic overdoses, and remember now they may be mixed with polypharm, and this may be prescribed, or the patient may be taking other things. So if it is mixed, again, Tylenol can be mixed, NSAIDs can be mixed with narcotics, morphine, derivatives, and so think about it. So let's move on to the next one. So barbiturates, we don't necessarily carry barbiturates, but we may carry benzodiazepines. Barbiturates will cause respiratory depression, CNS depression. They will cause also cardiovascular depression, but usually it's just depression. So in it by itself, again, we're not so worried about respiratory arrest as we were with a narcotic overdose, but we can anticipate that there's going to be some altered mental status, slurred speech, and such, all the way down to coma. We may have some respiratory issues, and may have some hypotension as it depresses cardiovascular in nature. We try to alkalinize the urine, and if early, we may even give some activated charcoal, and these go, again, throughout all. Follow your local protocols as to what we want to do. Again, the charcoal will bind with the toxin so that it's not then continue to be metabolized or denatured, so that it can be metabolized into the bloodstream. And so we're trying to bind it and then excrete it before it gets into the bloodstream. So now we do have some cases of patients that they are on benzos now, benzodiazepines or diazepine. Again, you would know this is Valium. We carry Versed, Valium. Other people might be taking lorazepam, Ativan. These are maybe used in conjunction for anxiety disorders, but they may be given for other things. And people can get these off the street if they're willing to just find the vendors for these, or the dealers or pushers. So these will cause, again, respiratory depression. They'll cause CNS depression. They'll cause cardiovascular depression, but we're not looking at respiratory arrest. Think about it, though. If there's polysubstance, if there's alcohol mixed, if there's narcotics mixed, if there's barbiturates mixed, we can compound the symptoms of these. Again, so we just support their respiratory effort. If given early, we may be able to absorb it with activated charcoal. The antidote for this medication would be Romazicon or Flumazenil. All right, so let's move on to the next one. So we got some antipsychotics. Sometimes they call them neuroleptics. These are like Haldol, Thorazine, clozapine. These cause sedation. They seem to be obtunded. There's some hypotension as it decreases CNS. There may be some respiratory issues. We may see some dysrhythmias. in concurrence with tricyclic antidepressant administration or ingestion, and it can lead to some seizure activity. We don't have a specific antidote. We want to monitor the airway, breathing, circulation, and again, we might combine therapy with giving them activated charcoal. Again, what we should know is that when it goes in, it's a gritty substance. It's very thick. It's hard to swallow. It causes a lot of reverse peristalsis. They may even regurgitate and vomit this. And so what was concerning here is that if they're not entirely responsive, that they could vomit this stuff up and they could aspirate it. And so we don't want that to happen in these type of cases. So think about that. Now, other medications that they may be taking are anticonvulsants or AEDs, anti-epileptic drugs. I know we use acronyms kind of interjectly, but these anticonvulsants or anti-epileptic drugs fall in categories of like Terigol, phenytoin, or Dilantin, and valproic acid. Now, there's no specific antidote, although we may end up seeing them having some anticholinergic effects, CNS effects where they become drowsy, and they can cause maybe some respiratory depression. Calculate the drugs, and use times these are used in conjunction with one another because they don't have good control over seizure or the breakthrough seizures, as I mentioned to you in the epilepsy and seizure lecture. We try to give medications that would curb the seizure at least 50% of the time. So it's not right trying to stop all seizure activity. As the medications don't work, we try to increase the dose, or we end up using multiple meds to try to decrease seizures. These try to decrease the seizure threshold so that seizures don't break through. Eventually, if there are multiple meds and they're suffering from the side effects of these meds, then they're elected to, remember, we had some kind of surgery. Now, use the idea of your farm books, your PDRs, your drug reference manuals to look up these meds, because these aren't meds that you commonly see or use, but if given in their overabundance or toxic levels, can lead to a lot of CNS, cardiovascular, and respiratory depression. And again, there's no specific antidote for those. Then there are other medications that we take over the counter, antihistamines. So we're looking at Benadryl or diphenhydramine. Again, this some of the effects are more like cholinergic effects. They become very sedative or sedate, nausea, vomiting. You may have some pupil dilation. Follow the anticholinergics. Again, another anticholinergic that you carry on the ambulance is atropine. That's correct. And so remember, it's like dilation, vasodilation. You're looking at increased heart rate, decreased GI stuff. So think about that. Theophylline is another medication that we hardly ever use anymore. It was an asthma medication in the past. There may be use for it if these people are refractory. Their meter dose inhalers, the anti-inflammatories, the steroids that they're taking, and long-acting beta agonists aren't working. They may be placed on theophylline. Theophylline is a methylxanthine. Refer back to your drug formulary of this drug. We used to watch for this, or we used to administrate this during status asthma. So it's going to present itself with some cardiac arrhythmias and seizures. And again, there is really no antidote for these drugs. So to recap, anti-epileptic drugs or EEDs, carbamazepine, Dilantin, valproic acid. There are no real antidotes for these. It's just trying to figure out what the symptoms are and then treat those symptoms. And then again, the anticholinergic or diphenhydramine is similar to anticholinergic effects. There is no specific antidote. It's just absorbing the material and then trying to get them to the hospital. And the last one is theophylline, which is a pretty great cardiac stimulator. So look for the arrhythmias that result from this methylxanthine and revert back to your formulary.